Welcome to Grand Rounds in Urology, the UroEdge Learning Center. I'm Diane Newman. I'm a urology nurse practitioner and a pelvic floor specialist. I'm the Senior Editorial Director of Grand Rounds in Urology. I'm very excited today to introduce you to Professor Christopher Chapple, who's a professor of urology at the University of Sheffield in United Kingdom. Welcome, Chris. He's going to talk to us about a recent publication on urodynamics and whether they're still useful.
Thank you very much, Diane. I'm extremely honored to be invited to talk on this medium and to this group. I have worked in the field of urodynamics, and you and I have known each other as colleagues and friends for many years. What is the reason for this consensus report, which I coordinated? The rationale behind it is that I was involved in two large randomized controlled trials in the United Kingdom, sponsored by our government, which were looking at the unselected use of urodynamics across the population. As you appreciate, in the UK, we have a largely nationalized healthcare system, and the principle was to look at the cost effectiveness and utility of using urodynamics in both male and female patients. The problem is, if you interpret that out of context, it looks as though, as I will describe to you, that urodynamics doesn't have any further role. Now, I'll qualify the term urodynamics. Urodynamics is a hierarchy of different investigations, but in the context I'm using the term urodynamics, it means pressure flow plots. And this is a paper which is published recently in the journal European Urology, and I was very honored, as you can see, by a number of colleagues who joined in on this publication. And with more ado, I will now move on to the findings of this. The first thing, just to set the scene, is that you see what you want to see. And you can either see here an elderly lady or a young lady. It depends how you interpret information which is presented to you. Many years ago, when I trained with my mentor in this field, in reconstructive urology, female urology and urodynamics, Richard Turner-Warwick, he always used to use the term, the bladder is an unreliable witness, which he first published in Urological Clinics of North America in 1979. The reason for this is that the symptoms that are exhibited by disorders of the bladder are not disease-specific. Patients report them in different ways, depending on their interpretation of those symptoms, the effect they have on the patients, and obviously tempered by their knowledge in the field. And we're not blameless as clinicians and healthcare professionals, because we interpret symptoms as we mean to interpret them, based on our knowledge, our expectations, and indeed our individual biases. I show you this picture because it's quite a historic one. It's a picture which is the first meeting of a group who introduced urodynamics into clinical practice. It's a multidisciplinary group involving both gynecology, anatomy, neuroscience, and you can see at the bottom here with a beard, Ty Halt. And you may know Ty Halt from Halt's rings, which were often used many years ago. I'll come to those in a minute. This is Turner-Warwick. This is Derek Griffiths, who was the brains behind pressure flow studies, a physicist. And here's a young research fellow, Paul Abrams, who's peeking his head over the back of the great and the good, and who did his thesis with Derek Griffiths, Abrams Griffiths normogram. Now, a very English thing, but there's Humpty Dumpty, and they called it the Humpty Dumpty Club. Why? Because within Lewis Carroll's work, there's the phrase, I use a word, it means just what I choose it to mean, neither more, nor less. In other words, if you're using terms, you need to know why you're using them and what you mean by them. And this led on to standardization of terminology, which is led by the International Continence Society. And indeed, as clinicians, we all appreciate that what we're dealing with are storage, voiding, or post-micturition symptoms. And let's face it, the storage symptoms are the most bothersome. Indeed, those are the reasons why most men with so-called prostatism, or bladder BPH so-called, come to see us. It's the storage symptoms, not the slower flow. It's getting up at night. It's the urgency, the key in the door syndrome, and so on. But of course, voiding symptoms are important, and post-voiding residuals, and so on, are really very important too, particularly if you're not emptying your bladder to completion, which of course can cause storage symptoms. This is a paper which, if you look at it methodologically, is faulted because it was self-reporting of symptoms by patients, but nevertheless, it emphasizes the fact that symptoms are not gender-specific. If you look across there, the whole gamut of symptoms, storage, voiding, and post-micturition, can you see any marked difference between men in purple and women in yellow? Well, the answer is no. So you can see you can't make a diagnosis just on symptoms. And indeed, if you use Tyer-Holt's rings, which have been modified, if you look here at the female situation with incontinence, for instance, or storage symptoms, you can see that there's an overlap between stress incontinence, urgency incontinence, so-called mixed incontinence, and sensory disorders, and across the whole field of lower tract symptoms. And the same goes for men. BPH is a histological condition. It is not a clinical condition. Benign prostatic enlargement is what causes the problem, which occurs in around 50% of men by the age of 75. And a half of those men, a quarter in total, with a so-called benign prostatic hyperplasia, the histological problem, actually have obstruction. And of course, they're lower tract symptoms, which can be due to the obstruction, or to storage symptoms, or due to so-called overactive bladder symptom complex. So the gist of this message is, yes, symptoms are important. They bring patients to see us, but you can't by itself use symptoms, whether it's OAB or BPH, to make a diagnosis without qualification. And across the board, of course, working in the field as urogynecologists, urologists with interest in functional urology, nurse practitioners, and other paramedical specialties, we're dealing with patients on a medical basis as well as a surgical basis. And we're talking about renal dysfunction, we're talking about CNS disorders, we're dealing about cardiac problems, heart failure, and so on, which may lead on to nocturnal polyuria, in other words, producing more than a third of 24-hour production at night time, and of course, diabetes, pituitary disorders. So you can see that it is a mixed picture, which is very important for us to consider as clinicians. Now, a number of years ago, I used the term very much that symptom assessment and symptom scores are important as a quantification of symptoms, are the objective assessment of subjective parameters. And as I've mentioned to you, these subjective parameters are not disease-specific and are not diagnostic. Urodynamics is a subjective assessment of objective parameters. As clinicians, we use our assessment of the individual patient based on these urodynamic parameters. If you like, we're using Bayesian type probability, as Adrian Wag, my co-author on the paper, pointed out. In other words, we add to the probability based on the original facts and based on new investigations such as urodynamics. And the art of this form of medicine is defining how to investigate the patient and when to use a pressure flow study, because the gist of the papers I've mentioned emphasizes that if you use pressure flow studies in an unrestricted fashion or carried out by somebody who's not experienced, who doesn't take the patient's history, who doesn't look at the other parameters of comprehensive medical assessment, CMA, then you will miss the whole point of the use of this type of investigation. So urodynamics, and this is an old slide that goes back right to the development of urodynamics back in 1969 by Turner-Warwick, Bates and Whiteside. You can see that, of course, the frequency volume chart. Now, many clinicians, particularly colleagues who are not working in this field, the subspecialty field in urology, don't use bladder diaries. Flow rates, of course, most people use, post-voiding residuals, pressure flow studies or urodynamics, and of course, particularly for neuropathic problems or patients, for instance, complex female patients where you're looking for the diagnosis of urodynamic stress incontinence, video, in other words, contrast studies are useful. And of course, pressure profilometry and neurophysiological investigations are used in specialist units. Now, these are the two papers that I'm mentioning. This paper published in European Urology on the left, led by Marcus Drake, and the paper here led by Mohammed, as you can see here, who basically from Aberdeen developed the protocol with myself, which was to look at the unrestricted use of a pressure flow study for patients who had not responded to initial treatment for urgency incontinence or mixed incontinence, which is urgency predominant. And you can see on the left here, Marcus Drake's study, which I was also involved in, was to use the pressure flow studies in men who are going to undergo prostatic surgery who had failed medical treatment. In other words, to see if this added predictive value to the diagnosis. In other words, whether you could tell the patient they'd do better from surgery. And the same here with the future study. The one on the left was the study here, which was the study from Marcus Drake, which was male, and the future study on the right, which was the one dealing with overactive bladder. So essentially, what these studies showed is that the unrestricted use of pressure flow studies did not add anything to the diagnosis. But both studies were not powered to look at subgroups within them. And of course, when you're looking at a pressure flow study, you need to look at the quality of the urodynamic study. I'm sure you'd agree with me, if you leave a pressure flow study to somebody who's not experienced, who's not versed in the use of the equipment, then it becomes a study which has limited value. The patient has to be involved in this, giving the history. You need to know all of the baseline information, the bladder diary, the post-voiding residual, in male patients in particular, the flow rate, and based on this, you can then move on. So in the upstream study, which was the male study, Marcus Drake, you can see this was good units who'd been involved in this randomized control trial. You can see 5% of the diagnosis on secondary reading, central reading, were erroneous because of faults with the urodynamic technique. And in the future study, it was very much the same, 5%. Central reading, therefore, was very important in these studies. There was another paper which looked at two studies looking at the male patient, including the upstream study as one of them, and the conclusion was that equipment wasn't always serviced properly or calibrated. Patients weren't asked to do cough tests every minute, as suggested by the ICS. And again, there was about a 5% error rate in interpreting the studies. And these were, again, specialized units who were recruited to these studies. So the importance of a pressure flow study is you need somebody experienced who takes a history, considers the hierarchy of the different types of urodynamic assessment, the Bayesian type approach, in other words, where you follow an algorithm and you look at the strength of the probability of something being appropriate based on the use of that. And at the pinnacle of that, a pressure flow study used appropriately will help. Now, in the future study, for instance, we found that 13% of patients who appear to have a mixed incontinence, which is predominantly urgency incontinence, in fact, the predominant problem was urodynamic stress incontinence. But it wasn't powered to look for that. So across the board, the conclusion was that pressure flow studies weren't helpful. The next thing is the individual patient characteristics. So as I mentioned in the upstream study where this was looked at, you can see that comprehensive clinical assessment and pressure flow studies were used to identify specific subgroups of men in the secondary analysis at risk of unfavorable outcomes. And they did find that there were groups where that was the case, but the study wasn't powered for that. And I've already mentioned in the future study that 13% of patients, in fact, had urodynamic stress incontinence. So the problem with those two studies, which were commissioned by the government to look at health economics and cost effectiveness, in fact, were correct that across the board, pressure flow studies aren't appropriate. But if used specifically, then it still remains the case that a pressure flow study is a vital part of investigation in specialist assessment of patients who fail to respond, either males to initial medical treatment or women and males with overactive bladder type symptoms to initial management before going on to botulinum toxin or to sacral neuromodulation. And so it's a selection of the patients which is essential. The role of urodynamics is to increase the degree of certainty of a diagnosis. As Alan Ween pointed out in this group, you want to be able to tell somebody that on the balance of probability, you are likely to have a better result because the pressure flow studies, despite the fact that you may have a slightly increased residual or a flow rate which is actually quite reasonable, in fact, you're going to do well and it's going to improve your symptoms. So these are the factors that one needs to consider in any individual, which mitigate against a good outcome, and where pressure flow studies can be very helpful to provide the best outcome for the individual patient, which is, after all, what we, all of us as clinicians, are trying to achieve. Thank you very much indeed for your attention.
Thank you so much. I mean, I found your paper really fascinating because you bring up a lot of good points, especially this is a problem in the US with who is doing the urodynamics. You're right? It has to be really someone who's well-trained and understands, because many times you come out of reading these studies and then you're not really sure exactly what happened with the patient during the study. But do you think, what is the message for clinical practice, though? You know, I think that's the million-dollar question, right? What should we do? I mean, you're right that we should really do a better assessment to know which patient really needs these studies. That's true. A lot of times, like the one study showed that their symptoms seem to be mostly urgency predominant, right? But then you saw stress incontinence. But then it goes back to what was the patient complaining of? What were they bothered about? So I was trying to figure out, where does this fall within practice?
Thank you. I think that's the key point. I mean, ultimately, what it comes down to is the structured approach, isn't it? So you take a good history, you realize that the symptoms can be misleading, as I've mentioned. I think it's essential that patients fill out a bladder diary. It's often neglected by medical clinicians. I must say, nursing colleagues, nurse practitioners, nurse specialists are much better at the initial assessment of patients because they actually use bladder diaries effectively. They take a good history and they also then move on. I'm afraid sometimes, as fellow surgeons, myself have probably been responsible for that. We're always rushing around the place and we really need to make sure we follow these basic issues. The second thing is just using a pressure flow study as a rumper stamping exercise, really from these two papers, shows that that doesn't actually contribute much across the board. But if you can see a patient, for instance, who's got symptoms which don't really fit too well, who's got a bladder diary that shows, for instance, if it's overactive bladder symptom complex, where the volumes are good and they seem to be emptying their bladder completely, and maybe they're drinking too much. So they don't need to go on to a pressure flow study. They just need to reduce their fluid intake. But if you haven't done a bladder diary, you won't pick that up. And I've had a number of patients like that. But of course, you've got a patient who's got a largish residual, who's also got a reduced volume voided, who's got frequency more than 8 times a day, and you're not quite sure whether they've got a bit of underactivity, which is causing the storage symptoms, for instance. Or on the other hand, you've got a female patient where the symptoms are urgency incontinence, but you suspect, based on your clinical examination, there could be a significant degree of stress incontinence, or vice versa. You may need to know the answer. And of course, I can give many different examples of that. Now, in terms of the person who's carrying out the urodynamics, again, it doesn't matter who they are, as long as they're skilled in the art. And they actually take it seriously. And it's not just something to rush through because, you know, it's I hate to say it, income generation too. It has to be because you're using it for the right reason in the right patient to produce a better outcome for them. And poor quality urodynamics is often misleading and may lead you down the wrong path anyway. So that would be my take on it. I hope I've not been too controversial.
No, I think that this actually brings up a lot of questions, but also a lot of discussion, right? Because, you know, a lot of, you know, to tell you though, a lot of the studies that are done by really high experts who know urodynamics. I mean, your whole paper is the who's who in urodynamics, okay? Alan, you, Marcus, Adrian, so, and Chris Harding. So it's people that, you know, I've listened to throughout the years. And then you come into practice, and the individual who may be ordering it, prescribing it, or doing it really doesn't have that knowledge. And I think that's what we're grappling with, both, you know, where you practice and where I practice. And it's a hurdle that we can't seem to get over. But I think that, you know, I thought why I asked you to do this is I found your paper very informative, but also thought-provoking, right? You know, we got to question this and see who we're doing it and what is it telling us. But what I really like what you talked about is the most important thing is the patient history. What are their symptoms? And what the patient tells you may not be what's showing you on the diary. Isn't that, we see that a lot?
Yeah, I think that's right. And, you know, I must say, I find a bladder diary one of the most useful tests out. I'm sure you do too.
Right.
Because, you know, people will say, okay, you know, I don't drink very much and I'm going 15 times a day. You get them to fill out a bladder diary and you get a totally different picture. They're drinking, you know, 5 or 6 or 7 pints of fluid a day. And then I don't find measuring intake very helpful across the board. I think if somebody has got, you know, they're actually got a very strange picture, then I'll get them to measure intake. But after all, fruit and vegetables are 90–95% fluid.
Right.
And I mean, for an example, I had a professor of law who was referred to me. He'd been investigated by colleagues around the place. He'd actually had Botox. He had storage symptoms. He was no better. I did a frequency chart, and it showed that he was actually drinking about 6–7 pints a day. So I then did, you know, got him to measure what he was drinking, and he was more than half of that was coffee. He reduced that, and he was cured. You know, so that's.
Well, and you're so right what you're saying. I had a patient who was in his mid-50s, saw me for BPH, a new patient, and had this significant actually frequency late afternoon and at night. I just couldn't believe the volumes he was telling me. Long story short, he had a 700 blood sugar. And you know, it was only, and I didn't think, you know, I listened to his symptoms and I thought, oh, he's got BPH, blah, blah, blah. And I finally said, because I couldn't kind of believe what he was telling me, how often he was going, I said, please, I want you to do a diary. And when I saw it, I was just like blown away by it. Okay. And you're right. And he really had polyuria. And it was really because he had undiagnosed diabetes. So, and again, that's not everybody. Like what you're bringing up is not, but it gives us another picture of what that patient is doing.
Yeah.
So I'm with you 100%. And I think that's actually what I got from the publication is we got to be a little bit better about identifying those individuals who really need specific urodynamic tests.
Yes, I think that's it exactly. And I mean, as Adrian Wyatt pointed out, you know, this is really a Bayesian probability approach. You're trying to strengthen the strength of the probability, if you like, by building on the initial data. And that's where you need to ask yourself, what is a pressure flow study actually going to tell me? Because let's face it, they are embarrassing for patients, particularly female patients, particularly for males carrying it out. You know, asking them to stand there and pee, you know, all the rest of it to void in front of you, you know. So I think that's another factor which I think is so important. You know, it's not nice for patients undergoing urodynamics, but it may be necessary. But, you know, particularly where you're struggling to know if you're doing something which is going to make matters worse for them. So, you know, you really want to be doing, you don't want to do, it's the old story in medicine, do no harm. And that's where I'm coming from on that. So I'm very much a urodynamicist, as are you. But I think it's really a matter of just you know, at first sight, I was worried with these two papers that people would say, oh, well, urodynamics isn't any use. Let's give up doing it. I don't think that's the case. I think it was trying to reset if you like, the balance there.
Thank you so much. I'm with you 100%, and I really appreciate you. And this is a nice review for us here in my country. So thanks so much.
It's a great pleasure. Nice to see you. And I look forward to our next meeting.